Hello and welcome to the Clinical Care Options Infectious Diseases podcast. I'm your host, Zachary Schwartz. In this episode, we discuss what pharmacists need to know to provide high-quality HIV care beyond viral suppression. We include treatments and tips for addressing and improving patients' quality of life. I'm joined by Dr. Lucas Hill from UC San Diego Skaggs School of Pharmacy and Dr. Bernadette Jakeman from University of New Mexico College of Pharmacy. For more information about this program and to follow along with the slides, or register for one of our live sessions in this series, visit the links in the show notes. And to get access to all of our new podcast episodes, you can subscribe to the CCO Infectious Disease podcast channel on Apple Podcasts, Google Podcasts, or Spotify. Let's get started with a case study from Dr. Jakeman.
I'm going to go over case one, and it's the topic of addressing internalized stigma with long-acting antiretrovirals. Our case one is a 42-year-old man with HIV diagnosed 1 year ago. The patient, since diagnosis, has been taking bictegravir, emtricitabine, and tenofovir alafenamide. The patient has been adherent with the most recent HIV viral load of less than 50, so the patient is undetectable. However, the patient does confide in you today that taking a pill every day reminds him that he has HIV, that he has an infection, and this is concerning for him. He has no other past medical history that's significant or other chronic medications. Looking at his labs, you can see there that his current CD4 is 521. He does have resistance testing with a K103N identified, which is the most commonly transmitted drug resistance mutation, conferring high levels of resistance to nevirapine and efavirenz. This patient has subtype B. You may or may not have that available to you, but that is the most common HIV-1 subtype. You can see that the patient's hepatitis B core antibody is negative, so the patient has not been exposed, but the hepatitis B surface antibody is positive, so the patient has been vaccinated. Hepatitis C antibody is negative, serum creatinine is 0.7, LDL 110, HDL 42, and the patient's current BMI is 23. So should ART switch be considered for this person? So it's important to periodically assess whether antiretroviral changes can be considered in patients to optimize quality of life, even in the setting of viral suppression. So reasons typically that we consider are to simplify the regimen by reducing pill burden or dosing frequency, enhancing tolerability or decreasing short and long-term toxicity, to mitigate or prevent drug-drug interactions, to eliminate food or fluid requirements. And then in our case, we can consider to switch to a long-acting injectable regimen to relieve pill fatigue or decrease potential stigma or disclosure concerns associated with taking an oral antiretroviral medication each day, also allowing for optimal use in pregnancy or cost considerations. So there is evidence that long-acting antiretrovirals may reduce internalized stigma. So in 2019, 688 people with HIV were surveyed about their hypothetical interest in potentially switching to a long-acting injectable, considering that that long-acting injectable was equivalent as far as cost went. And patients expressed interest, or the interest was highest among those people who had perceived stigma from their daily oral antiretroviral therapy, or people that were stressed by taking that daily regimen. And then also younger people, as well as people that were recently diagnosed, had the highest interest. Another observational study that included 53 patients that were already enrolled in the Atlas 2 and FLAIR. These patients at the US and Spanish sites, they were also asked about their experiences with long-acting. And they described freedom as the main benefit. So both logistical freedom, not having to take a medication every day, not having to try to refill their medications, not worrying about packing them for travel, things like that, as well as psychological freedom. So not having to worry about disclosure or the stress related to taking the daily medication. This was also seen in the SOLAR study as well. This looked at oral bictegravir, emtricitabine, and TAF, and patients were randomized to either stay on the oral regimen or switch to the long-acting cabotegravir rilpivirine for every 2 months. The long-acting was found to be non-inferior as far as virologic efficacy. And what they also found is that patients actually prefer the long-acting injectable for a number of reasons. They also conducted these HIV satisfaction questionnaires. So these are 11-item questionnaires with each of them having 6 points. And they found that patients that were on the long-acting injectables had an increase or an improvement in their scores at 12 months, whereas the patients who remained on oral regimens actually had a decrease. So there's a lot of potential quality of life improvements that can be addressed with patients taking the long-acting injectable. So going back to our case, again, this is a 42-year-old that is recently diagnosed about a year ago, has been on BIC, FTC, and TAB, has been adherent and is currently undetectable, but it has expressed that he is concerned about taking an oral regimen every day. So should an ART regimen switch be considered for this person? So for this case, again, we want to periodically check in with patients and see how they're doing on their regimen, even if they are undetectable. And in this case, we're going to switch to a long-acting antiretroviral regimen, which can improve quality of life for people experiencing internalized stigma with oral ART regimens. So the question has definitely come up because we have a number of patients that want to switch to long-acting injectables who we don't have a lot of history on and who are undetectable. So we are currently using this in our clinic setting. It's the proviral HIV DNA genotyping. So traditional genotypes, you're only able to get sequencing for mutations if you have HIV RNA levels of 500 or greater. With this proviral HIV DNA genotyping, the big thing with this is it can be used at any HIV RNA level, even if the patients are undetectable. So when HIV infects host CD4 T cell count or T cells, its genetic material is integrated into the host genome as proviral DNA. So some of these CD4 cells survive, and that latent proviral DNA can be used and extracted, and then through PCR we can determine potential archived mutations that we might have to consider in that patient. The current recommendations are that these genotypes can be considered for individuals with suppressed HIV-1 RNA when optimizing ART. For our particular patient case, this patient we have a baseline resistance test with the traditional genotyping. This patient has been successful on their first regimen. We would not expect any emerging resistance to occur. So this would be really unlikely to provide us any valuable information. So we would not use this for our current case. If you have cases where a patient, you might be concerned about resistance, it's really important to get a good drug history, but if you don't have a lot of data available, this can be helpful. However, the guidelines do recommend that results be interpreted with caution, and the main concern is that they may not detect all drug resistance mutations. So there still could be mutations that you are not picking up with these genotyping tests. So for our patient, again, there's no additional value for using the proviral DNA genotyping for this patient because we are pretty confident that the long-acting should keep the patient virologically suppressed. So we can switch the patient to the long-acting cabotegravir plus rilpivirine every 2 months. The patient doesn't have any contraindications. And then we can monitor for maintenance of viral suppression. So we usually do this 4 to 8 weeks. At our clinic, we're doing it before injection 2. And then if they're on the Q2 months, we're also doing it prior to injection 3. We will check in with them about adverse events and also treatment satisfaction. So I also remind patients when we're talking about this as an option, if this is something that they decide doesn't fit with their lifestyle or they do not like it, they can always go back to orals. So just letting them know that they have that option, I think sometimes is helpful. Opening it up for discussion. So just wanted to ask Dr. Hill, so in what situations are you using proviral DNA testing in your practice, and how is it being used to affect pharmacotherapy decisions?
Yeah, thank you. So it's a good question. And, I know that the use of proviral DNA resistance testing is somewhat controversial. And I think a lot of different practices are using them in different ways or not using them. We generally are using archives for various situations, in terms of evaluating for long-acting ART with cabotegravir. If we don't have a baseline genotype or a prior resistance test, we're considering getting these before switching just because of the frequency of transmitted NNRTI resistance and knowing that, one of the biggest predictors of failure of the regimen is having baseline resistance to rilpivirine. But in general practice, I think these are useful when you have patients who you don't have a great documented history because they've been in other systems. You don't have any previous information about prior failures or things like that, and the patient might not be a great historian. I think these are useful tools that we can use. And I think it's just important about how they're interpreted in terms of how they're used to make decisions on therapy. And so we're very aware that these tests are not perfect and they do miss things. But also, if they do show up on the archive genotype, I think that they have to be considered with the acknowledgement that there's no actual data to support that impacts clinical outcomes. But if you see the resistance mutation on the archive, I think it's definitely something to consider in your decisions. And then going back to LA, a long-acting ART, I did just want to kind of mention that it's interesting for the CARE study, which was presented at CROI this year, which is looking at using long-acting rilpivirine in Africa. They did do archive genotyping at baseline for their patients, and they had very high success rates, despite I think it was around 10% having significant mutations to rilpivirine. So that data isn't fully published, and we have to kind of wait to see all of those final results and specifically what mutations were there and things like that. But it is interesting that had a limited impact on viral outcomes in that study.
Great. Thank you so much for that. That's great. I also have a question that's asking about insurance coverage. And this has definitely been one of the things that has, slowed us down, definitely in the clinic setting. But we have been pretty successful in switching patients without them having to try a number of medications beforehand. We've had a couple of cases where we do have to document prior use, but it just depends on the insurance. I would say that most of the time that is not a requirement.
Thank you very much to our faculty, and thank you to our listeners for joining in. To view the full program on Contemporary HIV Treatment and Prevention 2024, click on the links in the show notes for this episode. And to access all of our new podcast episodes, subscribe to the CCO Infectious Disease podcast on your favorite podcast player. Thank you, and we'll see you on the next podcast soon.